Okay, I hope everyone of you knows about the meningitis or the all the meninges. So we have the three meninges. What are these? The outer layer. That outer layer is known as the dura matrix. This is February 2023. So outer layer is what? The outer layer is the dura mater, and the middle layer is what? After the dura mater we have the subdural space. After the dura mater we have the subdural space. Then above the dura mater we have the epidural. This is what meninges, and this is what the space. Below the subdural space, what we have? We have the arachnoid mater. We have the arachnoid mater. So below the arachnoid matrix, what we will be having? We having the subarachnoid space. We having the subarachnoid space. So below that subarachnoid space, what we will be having? We will having the pia mater. What will be having? Pia mater. And below that pia mater, we have the brain parenchyma. We have the brain parenchyma. We have the brain parenchyma. See, if we have the, this is my brain on the this is the cerebral cortex and everything. So we will be having the three layers. We will be having the three layers. So just a simple diagrams or the rough diagram. So what we call it dura mater, we have the arachnoid matrix and we having the pia mater. I hope this is clear. The part that is present inside the brain. The part that is present inside the brain, we call this condition as the brain parenchyma. This part will be the brain parenchyma. So if there is any infection or any inflammation in the brain parenchyma, if any inflammation in brain parenchyma, we call this condition as the inflammation in brain parenchyma. We call this condition as the encephalitis. We call this condition as the encephalitis. But if there is any, like if you have the dura mater, arachnoid matrix and the pia mater, if any inflammation in the meninges, so we call this condition as the meningitis. We call this condition as the meningitis. I hope this is clear. Okay, we have the meninges, we have the brain parenchyma. If the inflammation of the brain parenchyma, we call this condition as the encephalitis. If the inflammations of the meninges, we call this condition as the meningitis. I hope this is clear and done. Now let's continue with the detailed explanation of the meningitis, because that is the important. See, when we talk about the meningitis we talk, that is the bacterial meningitis, that is the most common. This is the little big topic, so just be conscious or be alert. Okay, then meningitis, remember, this is what that is the most common here is the acute conditions. And which acute condition? That is the acute means bacterial. You can remember it as like that. The bacterial meningitis is the acute meningitis. So or if we will talk about the conditions like TB meningitis and the fungal meningitis, they comes under the TB or fungal. TB meningitis and fungal meningitis, they comes under the subacute meningitis. They are the subacute conditions. So just remember these things. Then meningitis, acute bacterial meningitis, this is the most common. Acute bacterial meningitis, it is the most common meningitis. It is the most common meningitis. See, we have the subarachnoid space, and where it is present? It is present between the subarachnoid space. It is present between the pia mater and arachnoid matrix. What it contains? It contains the CSF. CSF means cerebrospinal fluid. So cerebrospinal fluids, it is present in which space? Subarachnoid space. In both brain and as well as in spinal, in brain as well as in the spinal cord. Okay. Then remember, if there is inflammations, as I just told you, you can write it in the line as well. If there is a inflammation, of meninges, if there is an inflammation of the meninges and subarachnoid space, if the inflammation of meninges and this inflammation of the subarachnoid space, we call this condition as the meningitis. We call this condition as meningitis. But along with that, if there is an inflammation of meninges, or the we can call this meningitis, plus along with that, if there is inflammation of the brain parenchyma. So this include both meninges and this include as well as brain parenchyma. So this condition, we call this condition as the meningoencephalitis. We call this condition as the meningoencephalitis. So remember these things, meningoencephalitis. Now there is some factors that some organisms that cause the inflammation of these factors. These are some inflammatory factors, and the cause of these inflammatory factors are the, like, what is the causes, and I will tell you the most common cause of meningitis. The most common cause, this is MCC, is the most common cause of meningitis. And what is that? That is that is Streptococcus pneumonia. That is Streptococcus pneumoniae. So this is the most common cause of the meningitis. The most common cause of meningitis is what? Streptococcus pneumonia. What is the other most common, or the second most common cause? The second most common cause, remember, that is Neisseria meningitis. The second most common cause is what? That is Neisseria meningitis. So that you need to remember. Okay. The most common cause of the meningitis is the Streptococcus pneumonia. The second most common cause is the Neisseria meningitis. Please keep in mind, because whenever I will ask you, you can answer it as the, because that is the takya kalam for everyone. That is the Neisseria meningitis is the most common cause, but that is not true. Streptococcus pneumonia is the most common cause of meningitis. After the second most common is the Neisseria meningitis. Okay, what is the the property or the antigenic? Every bacteria, they have some antigen or some toxins is there. So what are these antigenic factors that that cause the meningitis? So antigenicity of these bacteria, remember, these are we have the capsular polysaccharide. So they have the capsular polysaccharide, and along with that, what they have the lipo-oligosaccharide endotoxins. What they have? Lipo-oligosaccharide endotoxins. Lipo-oligosaccharide endotoxin. Okay, so that you need to remember. See, antigenicity means you have the capsular polysaccharide. Along with that, we have the lipo-oligosaccharide endotoxin. What will be the clinical features? The clinical features or the clinical presentations we will see in case of meningitis. See, first of clinical features or the clinical presentation. CF is clinical feature. What is the clinical features? This is acute in onset. This is acute in onset. Okay. Then what we will see in this patient? There is a high grade fever. Yesterday we studied about the mild fever. Where we studied in the mild fever? Mild fever we studied in rubella. So just keep connecting the dots. Rubella, in rubella we studied that it will be less than 39 degrees Celsius, but here we are telling there is a high grade fever of short history. There is a short history of 1 day, or maybe the short history of 1 day or the 1 or maximum 2 days, and the patient will having the lethargy and drowsiness. Lethargy will be there, and the patients will having drowsiness, आलसीपन है ना, and बिल्कुल sust. So that is the lethargy types, and the drowsiness will be there. What is the classical triad we seen in this condition? See, the classical triad, we always remember, this is the triad for the meningococcemia. So this triad, remember, there is the altered sensorium. What is the altered sensorium? What is the altered sensorium? See, if any change in the personality or the behavior of the patient, so we call this condition as the altered sensoriums. मतलब थोड़ा सा भटक जाना, अपने behavior के में change हो रहा, rude behavior or the any type of the behavior that will becomes under the changes in the behavior and the personality, that is altered sensorium. Along with that, what we will see, we will be having fever, that is high grade fever, plus that is the one most important features of the what? Meningitis, that is neck stiffness. So if you are seeing the neck stiffness in the question, then you need to remember that it is the possible that it's asking us about the altered sensorium, fever, neck stiffness. So it may be have the provisional diagnosis of the meningitis. Okay, the neck stiffness, remember, it will be in minimum in the 24 hours we can see. Then you just need to remember there is a neck stiffness will be there. Now also remember that these patients will having the severe headache. These patients will having the severe headache by meningitis and inflammation of what? Meninges. So of course that will cause the severe headache. So where the severe headache we will see there is a on the frontal region. So we will see the frontal tightness, and the persons having the headache, that is feels like compression, like someone is compressing her frontal part or the frontal forehead, we can say. So someone feels like the compression is there. So the severe headache, we call this condition there is a severe headache or frontal tightness will be there, and it feels like the compressions. So that's why we call this condition as the altered sensorium plus fever plus there is a neck stiffness. In the severe headache, frontal tightness, and it feels like the compressions. I hope this one is clear. Okay. Then you need to remember that one condition is there, that is encephalitis. One condition is there, that is encephalitis. See, in case of encephalitis, we will discuss more about the meningitis, but here is the key catch point, that in encephalitis we see the fever, plus we see the altered sensorium. Yes, this condition we also seen in case of meningitis. Plus here we see the focal neurological deficit. So the focal neurological deficit will be seen here. Along with that, we will see the seizures in case of encephalitis patient, like the tremors will be there, and all these characteristic feature of the seizures will be seen in encephalitis. But the seizures, remember, it will not seen in case of meningitis. So that is the differentiating feature of meningitis and the encephalitis. Okay, I hope this one is clear. Now let's continue with our meningitis. See, in meningitis, we studied about the patient having the neck stiffness, the patient will having the lethargy, the patient will having the drowsiness. Now, other important features of the meningitis, remember that there is some sign we seen in case of that things, in case of meningitis. What are these? These are the Kernig's signs. What are the signs? These are the Kernig's signs. What happen in the Kernig's signs? So remember that if the patient's in supine position, the patients will be in the supine positions. Okay, the patients will be in the supine positions. So okay, the patients will be in the supine positions and with their knee or hip is flexed. So the knee and hip will be the flexed, and when we are doing like, if there is a pain on when we are doing the passive extension of the knee, so you will understand with the diagrams I will share you. See the Kernig's signs, what when it will be positive, if there is a pain, on passive extension of the knee. If you are extending, see the person is in the flexion, the person is in this position, but when we are extending the knees, that at that point we will feel the patients will feel the pain. So if there is a pain on passive extension of the knee, we call this sign as the Kernig's signs. I hope this one is clear. Okay, the person is the person is in these positions. The person firstly in these positions. Okay, so when he is flexing the second positions, he is flexing the knee. So this one is knee, and when he is flexing the knee, so at that times he is extending the knee joints. At that time the person will feel the pain, and that is known as the Kernig's signs. Other signs we have, that is the Brudzinski sign. What happened in the Brudzinski sign? The patient again in the supine positions. The patient is again in the supine positions. But and when we will do passive flexion, see there is a passive flexion of the neck. So we have the neck, and we are doing the flexion of the necks. So on this side, so when we are doing the flexion of the neck, so what will be there? It cause the simultaneously there will be the flexion of the knee. So these positions will come. So when you are flexing the knee, simultaneously there will be the flexion of the knees and flexion of the hip joint. Okay, just you need to understand these things. When I will share the image, now you just to understand that okay, this is the supine position, this is the flexion extension. So after that we will study the patient in the supine position and passively flex their neck. Okay, so when it will be positive, it will be positive when it causes flexion of knees simultaneously. Okay, I hope this is clear. See, if there is a neck flexion, so there will be the flexion of the knee or the hip joint that will cause the in this patient that will cause the flexion of the knee, and that sign is known as the Brudzinski signs. But if there is a pain on passive extension of the knee, that sign is known as the Kernig sign. So both these signs will seen in case of meningitis. Along with that, other signs we see, that is lymphadenopathy. Okay, what is the difference between the symptoms and the sign? See, the symptoms are the these are the like characteristics feature of that disease that patient tell us. जो patient हमें बताता है, that is the symptoms. What we diagnose, what the doctor diagnose, or what the doctor see, that is the sign. What the doctor see is the sign, and what the patient tell us, that is the symptoms. This is the difference between the symptoms and the sign. So there is a lymphadenopathy. Other than that, we can see there is a lymphadenopathy. Along with that, we will see there is a papilledema. Papilledema. In case of the meningitis, we see there is a rashes will be there. And remember that rashes mainly due to Neisseria. Mainly due to Neisseria. Meningitis that occur usually due to Neisseria or Neisseria meningococcus. So what will be there? The petechiae and palpable purpura. Palpable purpura also seen in which conditions? Where we studied the palpable purpura? Write me in the chat box. Palpable purpura. Where we studied the mnemonics as well. अरे यार पढ़ ही नहीं रहे हो भाई. तुरंत जवाब आना चाहिए सभी का यार, ऐसे नहीं होगा, है ना? बी सीरियस. Saturday, Sunday. Okay, next Wednesday you have the exam test. Wednesday you all have the test. What you all have test? Okay, whatever like jitna whatever the we will study. What Wednesday you all have the exam. So whatever we will study, that will be asked in the exam. Okay, and this test I will share in the common group, so everyone will answer. That's why your rank will be decided according to that. So Wednesday we will be having test, and whatever we studied, everything will be from here only. So about the vasculitis, glomerulonephritis, yes, it of course MCQs. Every time MCQs will be there. And so this type. So because I'm seeing that you are not answering anything. Some only the few students are answering. Other are not answering. Those who those who will not give the test, they will not allow for further classes. Okay, so make sure that you are giving the test. So be prepared for the Wednesday exams. Whatever we will study till Wednesday, everything will come. See, rashes, we have the meningitis usually due to Neisseria. Then we have the petechiae and palpable purpura, that is also seen in case of the meningitis. Along, if you are seeing, along with that, we can have the complicated. If there is a complicated, as well as we can having the non-complicated. We have the complicated as well as we have the non-complicated meningitis. Okay. Then we have remember the uncomplicated. The uncomplicated, remember, there will be the raised ICT. If there is a raised ICT plus there is a no impending herniation, everything I will discuss, so just keep patience. There is a no impending herniations. So in that cases, what we will do, the lumbar punctures. The lumbar puncture is advised. Lumbar puncture is advised. But if we are having the complicated meningitis, when we will call it complicated, see if there is a raised ICT, along with that we can see there is a impending hernia. What is the hernia? The impending hernia is there. Then in that conditions, lumbar punctures not advised. The lumbar punctures not advised. See, normally what happen? Normally what happen in conditions like we have the complicated or uncomplicated meningitis. In uncomplicated conditions, we will be having the raised ICT. We will be having the raised ICT, or in case of meningitis, we have the raised ICT that as we can see. But if you have the raised ICP, so when we are doing the lumbar punctures, we are putting the needles on at the L3, L4, and then we are withdrawing our cerebrospinal fluids, because cerebrospinal fluid, I told, that is present in the subarachnoid space, and in the subarachnoid space it may be present in the brain as well as in the spinal cord. So we are taking the lumbar punctures and we are taking the spinal fluids. But when we are taking the as the ICT is so much high, so when we are taking the lumbar puncture, that spinal cord also can come with that lumbar puncture. So that, or we have the no impending hernia is there. If it is when we called it uncomplicated, there is a no chances of hernia. Hernia is any structure that is coming out from our body, like if anything is coming, like the diaphragms or the intestine is coming from our abdominal parts, it's coming outside. So outward pouchings, that is called the hernia. In simple words, we can call this the outward pouching. It can be any structures, that is the outward pouching, that we call it the hernia. So if there is a raised ICT and there is no impending hernia, we can do the lumbar puncture. But if there is raised ICT, along with that we have the impending hernia. If there is a possibility of herniation, so in that conditions we will avoid the lumbar punctures. Otherwise, we will take the spinal cord along with the CSF. So that's why we will not do. Now also remember that in case of meningitis, you need to check the Cushing reflex also. Analyze the Cushing reflex. What is the Cushing reflex? See, this is the important or the sign for or the reflex from the physiology point of view. See, Cushing reflex will be when it will be there if there is any hypertension or bradycardia is there. Any hypertension or bradycardia is there. So they simultaneously what we will see, there is an increase in or raised ICT will be there. Raised ICT. So we have the simultaneously raised ICT will be there, that is intracranial tension will be increased or intracranial pressure will be increased in case of hypertension and bradycardia. So that we need to also analyze in the case of, that might be possible in case of meningitis. Okay, then we studied that there is a contraindications of the impending hernia of the lumbar puncture. So other contraindications of the lumbar puncture, and all in these conditions that I am writing, we need to take the lumbar examinations, because for the lumbar examination we need to do, see if there is a focal neurological sign, if there is a focal neurological sign is there focal neurological sign, we cannot do the lumbar punctures. If there is a immunocompromised condition, the person having the immunocompromisation, so just remember that immunocompromised adult. So in that condition also we will not able to the lumbar puncture, or lumbar puncture is contraindicated. If there is any person having the recent onset seizures, because there is possibility of the tremors and everything, so in that conditions we will also avoid. There is a impaired consciousness, so in that conditions again we will not do the lumbar punctures. And patient having the severe hypertension, bradycardia, along with the, as you just write, along with the impending hernia, with the sign of, if there is sign of impending hernia, then we will not do the lumbar punctures. Or all these conditions, if we need to do the lumbar punctures, first we will examine the lumbar situations, and we will do the lumbar examinations, and after that we can do the lumbar punctures. But most of the things, they are absolute contraindicated for all these things, like focal neurological sign, immunocompromised adults, recent onset seizures, impaired consciousness, severe hypertension or bradycardia with impending hernia signs. So in all these conditions, what we will having, so we having the impending, we will have the contra indication of the lumbar punctures. I hope is this clear. That remember for the meningitis, see we do the for confirmations we do the MRI. What we do? We do the MRI. Okay, this is MRI. Then remember we have the conditions like, okay, I hope this till now it's clear. Everyone wrote it. After that, what we have, see meningitis, we know that it can be possible, it can be caused by the virus, it can be caused by the bacterial, it can be caused by the TB, it can be caused by the fungal as well as like fungal like cryptococcus. So all these things can be caused. So remember, let's make a table. So here where write viral meningitis, bacterial meningitis, and this table is very important for all the exams, not for Crow 2. It's important for further final exams and for every exams, for like FMG and all those exams. It's important. Okay, let's write the normal value here. Okay, normal. So what is this? See, first we will check about the pressure in the CS of intracranial pressures, that we called is the opening pressure. So if opening pressure is there, if opening pressure, what is the normal opening pressures? Then we will check for the color. What is the color of the CSF? The color of the CSF we will check. What is the cell present in per millimeter cube in the CSFs, like is it neutrophils or the very high cells in the millimeter cubes. And then we can check about the type of cells, which type of the cells, is it neutrophils, is it lymphocytes, and what type of the cells is there. CSF, we will check about the CSF levels, like if is it normal or high level or no normal, and in that conditions we will check about the plasma glucose ratio, because like bacteria, if you talk, the bacteria, they love to eat the glucose, that's why we will check about the plasma glucose ratio, and also we will check the protein. See, all these things we check in case of the CSF. We will take the lumbar punctures, we will check all these findings. If opening pressure, what is the normal finding? The normal finding of opening, or the normal opening pressure, or the normal CSF pressures, that is 50 to 100, that is 50 to 150. 50 to 150. What is the color of the CSF? Normal color of the CS, they are the clear. What is the cells that is like present normally? That is less than 5. Then what is the like the type of the cells present normally? Then we have the lymphocytes. The lymphocytes are normal, usually like more than the other cells. The CSF or the plasma glucose ratios, that is 66% normally present. The protein is less than 0.5. That you need to understand. Now remember, we have the viral. So if we have the viral, see in the case of the viral, we see there is a normal and is either normal pressure or the high pressure will be seen, like around the 150 to 200. Now what is the color that we seen in these conditions? Again, that is the clear. Then what about the bacteria? See, in the bacteria we see, if we see, there is a high opening pressures, there will be the high opening pressures. In the TB again it is high, and in the fungal it is will the very high. The fungal, it will be the very high pressure in the CSF. In the bacteria, it will be the cloudy color. In the TB, it will be again, it will become the cloudy or the yellow. It will become the cloudy and yellow. Then it will become in the fungals, it becomes the clear or cloudy. It can be the clear and cloudy color. Then in the cells, if we talk, the cell normal cells per mm cube is less than 5. But in this condition, in the condition of the viral, so we have the normal to the high cells, is the either normal or the high. But in case of bacterial, they are the very high cells are present. They are present slightly in the TB, and less than 50 will be in the fungals. Okay, the type of the cells that we seen in case of the viral. Of course, in the viral, we all knows that which type of the cells will be there, that is lymphocytes. Which type of the cells will be there? That is lymphocytes. In case of the bacterial, which cell will be there? We see there is a neutrophils. Neutrophils. In case of the TB, again we see the lymphocytes. And in fungal also we see the lymphocytes. Okay. If you talk about the plasma glucose ratio, so I told you that bacteria, they love to eat the glucose. So bacteria levels, the glucose level in case of viral, it will be normal. But in case of the conditions like the bacteria or the TB, it becomes very low. It becomes the very low, or we can say in the low in case of bacteria, that is around less than 0.4. But in case of TB, it becomes very low, like around less than 30% glucose will be there. Less than 30% glucose will be there. Then we have the normal in case of fungus. In the fungus, there can be the normal or there can be the low. Both are possible. But if you talk about the proteins, then proteins, remember, they are again the normal to high, and around 0.5 to 1% will be there. And if we talk about the bacterial, so bacterial, remember, they have the high protein ratio, that is high protein will be there more than 1. But if we talk about the TB, there is a high to very high, means it will be 1 to 5. But in case of fungal, there is a usually normal. Okay, so need to remember this point. This is very important table for all the exams, and everything is clear from this table. See, we have the 4 conditions. We have the viral, we have the bacterials, we have the TB, and we have the fungals. We have the viral, bacterial, TB, or fungals. So in case of opening pressures, so normal, see, you need to remember what I am telling you now, or what I am highlighting in now. If you are seeing the bacterials, it will be the cloudy, cloudy yellow, so that means TB. If you are getting the neutrophils, of course we all know that neutrophils are seen in bacterial conditions. Plasma bacteria is how much percentage? 40, right? So there will be the lymphocytes and other those things. Then what we will be having, the CSF plasma glucose level in bacterials. So this is the less than 0.4%, or you can remember it as again, yes, it will be the less than 40%. 40% will be there. Okay, so it is less than 0.5, or we can call it like the 0.66, so that it will become the 0.4, and that's why it becomes the 40%. I hope this is no need to use the mathematics, but here what I write, just remember there is a low glucose in the case of the bacteria, and the TB, remember, that is a very low. I hope you understand the values terminology also. This is the less than 0.4, yes, it will be less than 40%. Here it is very low, that is it will become the less than 30%. Okay. Then you need to remember the protein. Just remember there is a high protein in case of the bacteria. Okay, so if I ask you, in the bacteria, which cell will be there? Yes, neutrophils will be there. Is in other conditions, what cell will be there? Lymphocytes will be there. Viral, we already know lymphocytes. TB, lymphocytes will be there. Protein will be very high in case of TB. The bacteria, the protein will be high. But if they ask you what the protein level will be very high in case of the CSF, in which condition? That is the TB meningitis. I hope this one is clear. Then remember, if we have the talk about the TB meningitis, so remember that TB and fungal, they both are subacute meningitis. They both are the, already we wrote it, so they are the subacute meningitis. And remember also the fungal meningitis. The fungal meningitis. What is the most common cause? This is MCC, is the most common cause of fungal meningitis. What is that? That is Cryptococcus neoformans. Okay, the Cryptococcus neoformans, that is a fungal meningitis, and that is what? That is the most common cause. How it will spread? It is spread with the inhalation, of the spore of the Cryptococcus, and that will lead to the fever, that will lead to the headache, and that will lead to the myalgia. In the patients. What is the treatment for the these conditions? Remember that what we will do, we need to give cryptococcus. Sorry, for the cryptococcus, what is the treatment we will do? We will do amphotericin B, amphotericin B, amphotericin B, along with that flucytosine, flucytosine. Okay, I hope this one is clear. है ना? And the TB meningitis, we know that is caused by the mycobacteriums, and in TB meningitis, headache will be the prominent feature that you can remember. The headache will be the prominent feature in case of the TB meningitis. And remember the fungal meningitis, the most common cause, if they will ask you what is that, Cryptococcus neoformans, and what is the treatment, that is amphotericin B plus flucytosine. Treatment of the all the meningitis we already discussed yesterday, so you can just go there and or you can write it here as well again. Okay, this is your base. Okay, the next one we have studied already little bit, that is the fever if the seizure is there. So what conditions we call this condition as the, yes, that is encephalitis. See, in case of viral encephalitis, normally the encephalitis when we talk, so normally or usually the most commonly it will be the viral encephalitis. It will be the viral encephalitis. And the most common cause of encephalitis, it is always the infectious cause. Most common cause of encephalitis, it is always the infectious cause. And always remember, in the infectious cause, which what will be there, that is herpes simplex virus 1, HSV1, or more than that, arbovirus. The first most common, that is HSV1, and the second most common is what, that is arbovirus. What is the second most common cause? This is the most common cause of the most common cause of the encephalitis, that is the infectious. The second most common cause is autoimmunes. The autoimmunes that cause the destruction of the encephalitis or the antibodies against the oven cell, that is the autoimmune conditions. So in that conditions we also having the we also having the encephalitis. The clinical features, we talk about the clinical features, so always remember there will be the acute onset. There will be the acute onset we will see in these conditions. After, along with that, we will see there is a behavioral changes, that we already altered sensorium. Yes, behavioral changes, altered sensorium, altered sensorium. Plus we will see the seizures within 24 hours. Plus there is a seizures within 24 hours. If you are getting the seizures within the 24 hours, along with that we will see the behavioral changes or the altered sensoriums. So in that conditions we can suspect that it can be the case of the encephalitis. Along with that, other features we can see, there is a reduction of the consciousness. The patient will having the feeling of the unconsciousness. Feeling of consciousness, there is a feeling of confusion. The person will be feeling of confusions. There will be the disorientation. There will be the disorientations, and there will the patient will be having lethargy, drowsiness. All these are the common features that is also seen in case of meningitis. So along with that, you need to understand that patient will be having the fever. The patient will be having the altered sensorium, and along with that there will be the reduction of the consciousness. The person will be in the confusion state. The person will be having disorientation. There is a lethargy, there is a drowsiness, and the seizures within the 24 hours will be there. And in the CSF, what we will see, in the, if we check about the CSF, we do the lumbar punctures and we find the CSF conditions. In the CSF we see the lymphocytic pileocytosis. Okay, like lymphocyte cells will be more. Along with that, we will see there is a normal, the glucose level will be normal in this condition. The glucose level will be normal in this condition. The glucose level will be normal in this condition. There can be the mild, like there is elevation of the proteinuria will be there. Mild elevation of the proteinuria can see, but the glucose level will be normal in these conditions. I hope this is clear. And for the management of the herpes simplex virus, we know the drug of the choice for the herpes simplex virus, we can go the acyclovir. What we can give? Acyclovir. Okay. Other drugs we can give for the for any other viral infections, we can use the ganciclovir along with the acyclovir. Because the see, normally we have the HSV1 or HSV1, then also the HSV2, and also cause the encephalitis, and after that we have the varicella, after that we have the varicella zoster virus, and along with that we having the Epstein-Barr virus that can also cause the Epstein-Barr virus that can also cause the encephalitis. We will having the HHV6, human herpes virus 6, and the, other than that we have the Japanese encephalitis virus that we also studied. So that is Japanese encephalitis virus. So that is can also cause the what? Encephalitis. So remember, in case of like herpes simplex virus and in case of like varicella zoster virus, what we need to give? We can give the acyclovir. But in case of Epstein-Barr virus, in case of Epstein-Barr virus, we can go for the ganciclovir along with that acyclovir, or we can give the, along with the acyclovir, we can give the steroids. Oh, let me write it here. For Epstein-Barr virus, we can give the ganciclovir plus we can give the steroids. And for others, some of the viral disease, we can combine the both ganciclovir along with the acyclovir. And for herpes simplex virus, HSV1 and 2, and also along with the varicella zoster virus, we can give the treatment as the acyclovir. And herpes simplex virus, the drug of the choice for the herpes simplex virus is what? That is acyclovir. I hope this is clear. And one more thing you need to remember about the encephalitis. See, if you have the HSV infections, in the HSV, remember always the temporal sides will be more affected. In HSV, the temporal side will be more affected. Temporal side will be more affected than the frontal sides. The temporal sides will be affected more than the frontal sides. In meningitis, we studied about that there is a frontal compressions will be there, but here we are talking about this. In case of herpes simplex virus, we will be having the temporal sides more affected. In other conditions, there can be the other regions as well, just like for example, when the Japanese encephalitis, that you don't need to remember, not so important. So Japanese encephalitis, we have the thalamus that is more affected, more than the basal ganglia. Okay, that you need to understand. And for the diagnosis of encephalitis, how you will diagnose the diagnosis. So this is the diagnosis of encephalitis. So how we will diagnose? With the help of RT-PCR. With the help of RT-PCR. I hope this is clear and clear to everyone. So this is done. Okay. I hope no one have any problem in this. Okay. So let's continue with our new topic. No, with the next questions. I think we completed everything. So one thing. Okay, so here is what varicella zoster virus. So we have already studied it can be caused by the varicella, it can be caused then by the Epstein-Barr virus. In that condition also, what we need to give? Acyclovir. Headache, weakness, vertigo, the tremors of the limbs. Tremor of the limbs, that is the symptoms that is seen in case of the seizures. See, seizures and epilepsy, these are two different terms. Seizures is what? The epilepsy ka chota bhai. So when we call this condition epilepsy, if you are getting more than 2 seizures within the 24 hours, we call this condition as the epilepsy. But if you are getting the seizures like after one time or just one time, then we call this just only the seizures. We can't call this condition as the epilepsy. Then in the tremor of the limbs ataxia, the mental confusion appeared on the 5th day of illness. Meningeal signs are negative. Of course, I told you. And cerebrospinal fluid examination is normal. So what is the answer? That can you explain these signs? So cerebrospinal fluid examination, what we study? Normally there is a lymphocytic that is present normally as well, and the glucose level is normal, and so all these conditions are normal. That's why we call this condition as the encephalitis. I hope this is clear. done. And meningitis, we don't see the tremors or the seizures. Okay. If you want to revise, we can revise it. See, we will having the dura mater, we have the subdural space, arachnoid mater, subarachnoid space, pia mater, and the brain parenchyma. Subarachnoid space, it is present between the arachnoid mater and the pia mater. Then remember, we have the meningitis. Meningitis, the most common meningitis is the acute bacterial meningitis. What is the inflammations of the meninges and the subarachnoid space? That is the meningitis. If the meninges are inflamed along with the brain parenchyma, we call this condition meningoencephalitis. What is the cause of the most common cause of the meningitis? That is the Streptococcus pneumonia. The second most common is the Neisseria meningitis. What is the antigenic property? Like capsular polysaccharide, lipo-oligosaccharide, endotoxin. So endotoxin, we know that is the like the antigenic features or the toxin factors for any disease. And a gram negative, that is the most potent in the gram negative organisms. This is acute in onset, high grade fever of the short history of 1 day, and lethargy will be there, drowsiness will be there. Then with the altered sensorium, fever, there is a neck stiffness in the 24 hours, severe headache, we have the frontal tightness, where the feels like the compression, someone is compressing the frontal part. Encephalitis, we study the seizures. So this you need to understand and put it in the box. Then what the signs we study, the sign we will study, this is not the topic, so just put it in box. This is just for differentiation between them, so you will easily understand that is the fever, neck stiffness. Along with that, if you're getting the seizure, that is the encephalitis. Sign we will see the Kernig signs and the Brudzinski sign, that is the important signs we study here. So remember these are the important signs. Then you have the Brudzinski sign. Along with that, we see the lymphadenopathy, there is a papilledema, there is a rashes, and the rashes will be the petechiae and the palpable purpura. Yesterday we studied there is a hemorrhagic rashes, so hemorrhagic rashes will be due to adrenal gland shutdown, that is due to complication of the meningitis, and that will lead to the meningococcemia. In that condition we studied that the adrenal shutdown is there, so adrenal shutdown, that will cause the adrenal hemorrhage, and this hemorrhage will be accumulated in the any regions, and they will give it the appearance of the hemorrhagic rash, and the petechiae will be there, or the purpura appearance will be there, that will be the palpable. The one palpable purpura we already studied in the Hinox colon purpura. Other than that, we studied that is a complicated or uncomplicated meningitis. If uncomplicated, there will be the no impending hernia, but if complicated is there, there will be the impending hernia will be present. Impending means impending hernia means there is a possibility of herniations is there. So in that condition, of course, we will not do the lumbar puncture. We don't want the spinal cord should come out. So in that conditions, we will not do the lumbar puncture. Analyze the Cushing reflex. So in that condition, if there is hypertension in the bradycardia in the place, if there is increasing hypertension, so that in that condition we know the Cushing reflex. If it is present, that is the that gives the strong history of the meningitis. What is the contraindication? The focal neurological sign, immunocompromised adults, all these you need to remember. For confirmation, we do the MRI. Then this table is very, very important. So you need to understand the opening pressure, the normal high pressure, high, very high. Then you need to remember the bacterial, there is a decrease in the glucose, and the neutrophil cells will be there. Along with that, we see the bacterial. Viral, you know that there is a lymphocyte. You need to remember the opening pressure of everything. So normal or high. There is in bacterial, the TB, there is a very high taper, but in the fungal, very, very high. So which CSF pressure will be very, very high in the condition in fungal. Then we have the type of lymphocytes, the type of the cells like lymphocyte, neutrophils, and we know that the TB bacteria, they love to eat the glucose very, they are very glucose lover, but bacteria, they are very less glucose lover, so they eat the glucose low, and they eat the glucose very, very fastly, so they become the glucose level will become more low in case of TB meningitis. Fungal meningitis, I told, that is caused by the Cryptococcus neoformans, and the inhalation of the spore of the Cryptococcus will cause the fever, headache, and myalgia, and that will the treatment for that condition amphotericin B and the flucytosine. I hope this is clear. Then we studied about the viral encephalitis, that infectious HSV1, the most common cause acute autoimmune conditions. Then we have the behavioral changes, seizures will be there, the reduction of consciousness or the focal neurological deficits will be there. Lymphocytes will be there, and the glucose will be the normal things. Then we will having the acyclovir. So remember that things, if you have the acyclovir, the management for the herpes simplex virus, and the drug of the choice for the herpes simplex virus is also the acyclovir. I hope had the diagnosis with the RT-PCRs, and the temporal side is more affected, and in the case of the meningitis, frontal side is more affected. There is a frontal compressions will be there. I hope this is clear and done. Chalo. Okay, bolo to bhai, okay. In which we give both the drugs like ganciclovir and both in Epstein virus. No, in Epstein virus we give the ganciclovir plus we have the steroids. Okay, just remember we can give the ganciclovir or acyclovirs. If you have the no, you can remember it like as if we don't have the ganciclovir available or the acyclovir available, we can go for the ganciclovir. But in case of the Epstein Barr virus, we have the ganciclovir. Along with that, we will give the steroids. Chalo 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 bulava. Chalo. Next questions we need to understand that. ठीक है, तो ये वाला क्वेश्चन everything okay, I hope. चलो, so the next question we have scarlet fever. This we already studied yesterday. Then the next questions, there is a dysentery that I just yesterday discussed everything. This one. So for today, there is a one more big topic, and there is a about the topic that you need to remember. So what is that? That you need to understand some milestone. You need to understand the weight of the baby, when it is increasing, when it is decreasing, how many teeth the baby should have. See, mother with infant visited the pediatrician for the expertise advice. Her baby was born with the body weight 3.2 kg. That is the normal baby. And body length is 50 centimeter. That is again the normal. He is 1 year old now. How many teeth the baby should have? Okay. So he is asking that 1 year old baby, how many teeth will be there in case of 1 year old baby that we need to understand. Okay. So let's discuss everything in details, and whatever the some milestone I will tell you today, that is more important. So that, and all milestone I will not tell, because whenever I will tell you everything, so you will not able to recall anything. So that is better, है ना? So better I will keep it less, so that you can easily mug up. See, what is the time now? Okay, let's continue from the starting, and like all these things you need to understand, because everything this is important, है ना? So what are the questions? Question number we have 23. See, we have the conditions like normally what we see, from the pediatric point of view. If we say the pediatrics normally we consider at the 0 to 18 year of the life. 0 to 18 year of the children we consider under the pediatrics. And remember that we have the three conditions normally. We have the prenatal, we have the natal, and the postnatal. See, we have the prenatal, natal, and postnatals. I think my voice is breaking. Yep. So we have the prenatal, we have the natal, and we have the postnatals. See, in the prenatal condition, if we say there will be the in the case of the prenatal conditions, what we will see, we see the patient having the ovum. The patient will call the embryo, or the baby will be called embryo, and sometimes we call the baby as a fetus. The natal stages we call when the baby has been delivered. So in that condition or delivering, that condition is known as the neonate. There is the early neonate, and there will be the late neonate. Then postnatal we will be having the patient like the toddler, preschool children, and there will be the school going children. So always remember we having the conditions like ovum. So when we call the ovum we called it as the when the like the egg will be 0 to 2 weeks, or the zygote will be the 0 to 2 weeks, and the embryo, when we call this embryo, the embryo will be considered as the 3 to 8 weeks time period. When we call this fetus, fetus will be 8 or the 9 week, or the 9 week till the birth. So 9 week till the birth we call this baby as a fetus. When we call this as embryo, this is 3 to 8 weeks. When we call the ovum, 0 to 2 weeks of the prenatal periods, or in the like during the in the gestation period. When we call the neonate will be considered as the 0 to 28 days. The 0 to 28 days. Early neonate will be considered as the 0 to 7 days. Then the late neonate will be considered as the 7 to 28 days. Okay. So neonate, early neonate, late neonate. The neonate will be there, that is 0 to 28 days. Early neonate will be there, that is 0 to 7 days, and the late neonate will be there, that is 7 to 28 days. The toddler you need to remember, that is the 1 to 3 year. The toddler you need to remember 1 to 3 year. Preschool you need to remember that it is 3 to 6 year, and the school you need to remember the baby having the 6 to 12 year, they called as the school going childrens. Okay, I hope this is important. Everyone should remember this. Neonate we called it less than like 1 month baby is known as neonate. Early neonate 1 week baby. Late neonate last 3 week baby. Okay, 7 to 28 days. Toddler 1 to 3 years. Preschool 3 to 6 years. School is going. This one you should remember, very very important. Neonate, early neonate, late neonate, and also you need to understand the embryo and the fetus we call this condition. Okay, what is the normal weight of the fetus? This is little boring. पहले बोल रहा हूँ मैं, है ना? Boring है थोड़ा थोड़ा, और that you need to learn as well. But we will make it like little enjoying so that you can enjoy. Normal weight कितना होता है? Normal weight of the baby. Normal weight is 2.5 to 4 kg. अगर 4 kg हुआ तो 4 kg का बच्चा, बड़ा बड़ा बच्चा, है ना? Big बच्चा. So that is more than 4 kg. That will become the big baby. है ना? After that, if we talk about the average weight of the baby, that is should be minimum around like 3 kg. That is should be 3 kg or around 2.8 kg. 2.8 kg should be there. When we call this baby as a low birth weight, the low birth weight when it will be less than 2.5 kg. But when we call this condition as the very low birth weight will be less than 1.5 kg. Then extremely low birth weight, we call this condition as the when baby weight is less than 1 kg. So low birth weight less than 2.5 kg, very low birth weight less than 1.5, extremely low birth weight less than 1 kg. Every point is important. This one is important, this one is important, this one is important. Okay, that you need to remember. Then after that we having the conditions like if we talk about the expected weight, if we talk about the expected weight of the expected weight of a 1 year old, that is 10 kg. The expected weight of 1 year old baby is what? That is 10 kg. So always remember the weight that is doubles by 5 months. The weight doubles by 5 months. The weight जो है वो डबल हो जाता है कब? 5 months में. And weight triples by, and weight it is triples by 1 year. Okay, the expected weight of the 1 year old baby, that is 10 kg. Then weight is double by the 5 months and it triple by the 1 year. What was the normal length in the question? That was 50. So here you need to remember the normal length at birth. The normal length at birth is what? That is 50 centimeter. The normal length at birth is what? That is 50 centimeter. 1 year old baby having the 75 centimeter. 2 year old baby, remember they will be having 100 centimeter. 12 year, no sorry, 1 year, after that 4 year. The 4 year baby will be having height, that is 100 centimeter. So remember the height is doubles by 4 year. The height double by 4 years. So if we are having the height, normal height at the birth is 50 centimeter, at the 4 year the height will become the 100 centimeter. That you need to remember. Then at the 12 year, what will be the height? The 12 year, what will be the height? 150 centimeters. So you can remember the height triples by 12 year. Triples by 12 year. Okay, this you need to understand. The expected weight of 1 year old baby 10 kg. Weight double by 5 months and triple by 1 year. Normal length at birth 50 centimeter. 1 year we have the 75 cent. 4 year 100 centimeter means height double by the 4 year. You can remember this one, and height triple by 12 years, that you need to remember. Okay, so height double by the 4 and triple by 12. Double by 4, triple by 12. Double by 4, triple by 4. Triple by 12. Now you can remember the height formula as well. Height formula. So remember the height formula. If you need to calculate the height of the baby, so remember, just consider the age into 6 plus 77. Age into 6 plus 77, that is the height formula. Then what is the next question is what? That is normal head circumference. Normal head circumference. Day 22A to 1 year kid. Day 28 to 1 year kid. Day 28 to 1 year kid. What we call this kid as the infant. What we will call this as the infant. Okay. Thank you for telling me. Day 28 to 1 year is what? That is called the infant. And the neonate is 0 to 28 days. What is the normal head circumference? What is the normal head circumference? That is 35 centimeter. The normal head circumference is what? That is 35 centimeter. See, 0 to 3 months. 0 to 3 months. 0 to 3 months, how many centimeter increasing? 2 centimeter increasing per month. The 2 centimeter increasing per month. 3 to 6 months. 3 to 6 months. How many centimeter increasing? 3 to 6 months, 1 centimeter increasing per month. 1 centimeter increasing per month. 6 to 12 months. 6 to 12 months. How many centimeter increasing? 0.5 centimeter per month. है ना? मान लो ये क्या होता कि अगर 2-2 सेंटीमीटर ही बढ़ता रहता तो पता चलता कि एकदम से मारा वो एकदम जाइंट बेबी बन गया. So if it is continuing 2 centimeter per month, 2 centimeter per month, 2 centimeter per month, then what will be the final stage after 1 year? That it will become the giant baby having the macro. There is a macro, what we call the conditions. Hydrocephalus conditions can be there, or all these conditions can be the possibles in that conditions. है ना? Okay. Sometimes what you see, that baby born having this was healthy baby, but normally within the first week of the baby, so there is a weight loss in the baby. So that condition, that is what? That is the physiological weight loss that occurs in every baby. There is a physiological weight loss, and how much weight loss will be there? That is a newborn baby loses 10%, loses 10% of body weight, loses the 10% of body weight. Okay, so that you need to remember, the physiological weight loss. The newborn baby, how many weight loss has been lost? That is 10% of the body weight will be lost by the normal baby or by the normal newborns. Okay. If you are stealing this, then you can also remember this one. I think the height measurement. For height measurements, what we use for height measurements? We can use the infantometer. What we can use the infantometer. You can use the infantometers. Then also remember for height measure, I think something for infantometer. No, sorry. I'm sorry. For length measurement, you need to use the infantometer. For height measurement, what you need to do? Height measurement, what you need to do? That is stadiometer. Okay. So this is, you need to remember, the for length measurements, what we used to do? that is infantometer. For height measurement, what you need to do, that is stadiometers. If the head circumference is more, if the head circumference is more than 35 centimeter, that what I was telling here. See, if head circumference is more than, if head circumference is more than 35 centimeters, so in that conditions, what we call this condition as the macrocephaly. If head circumference is more than 35 centimeter, we call this condition as the macrocephaly. If head circumference is less than -3 standard deviation, we call this condition as the microcephaly. But you need to just understand, there is the more than 35 centimeter, then it means that is the macrocephaly, or big baby having the big head. Okay, I hope this is clear, है ना? Just make a quick look. Ovum, embryo, fetus, neonate, early neonate, late neonate, toddler, preschool, school, normal weight, low birth weight, very low birth weight, extremely low birth weight. Then we have the expected weight of 1 year old baby. Then weight double by 5 months and triple by 1 year. Then we have the normal length at the birth, and that is 50 centimeters. Normal head circumference, that is head circumference. The head circumference, that is 35 centimeters. Okay, then we have the for length measurements, what we will be having, the infantometers. For height measurement, we need to remember that is the stadiometer. Physiological weight loss, remember, newborn baby loses the 10% of the body weight. I hope this is clear and done. Okay. Okay. The dental formula, if we talk, let's talk about the dental formula, because the question has been asked. What is the dental formula of the adult? That is 2 1 2 3. 2 1 2 3. So how many teeth we have? Normally in the adults we have the 32 teeth, है ना? So what are these? These are the incisor. These two, the in between, so we have the incisor. Then we have the canine. We have the premolar, and we have the molar teeth. So these are the 4 type of the teeth that we see. The first 4, above and below, they are the incisors. Then one on the side, that is canine, and on each side, one on each side, and on the both upper and the lower side, that is the canine. Then we have the premolar. Then we have the premolar, that is 2 on that side, 2 on this side, 2 on below side, 2 on below side. Okay, that will become how many? 2 2. It become the 8. Then molar, again they are the total how many number? That is total 3 here, 3 on this side, 3 on this side, 3 on this side. So it will become the 12 in number. So what is that? 2 1 2 3 multiply. If you divide the 2, see 2 1 2 3. This is the formula of one side. So if we have the 2 1 2 3, means we have the incisor. I am writing it again here. 2 1 2 3. 2 1 2 3. So this is what? This is incisor. This is incisor. This is canine. This is premolar, and this is molar. And when we will divide the two-sided, so it will become the total 32. Okay, I hope you no need to calculate. Then you need to remember about that. Which is the first molar teeth? Which is the first teeth, that first primary teeth? So one we have the one we having the mild, one we having the someone asks us, message me mild. Someone we have the one we have the milk teeth, one we have the milk teeth, that we also called is the temporary teeth, that will be fallen down, temporary teeth. Other than that, we have the other things, that is the permanent teeth. We have the other than that, we have the other teeth, that is known as the permanent teeth. See, the first primary teeth. The first primary teeth is what? That is lower central incisor. That is the lower central incisor. Lower central incisor. And develop at 6 to 7 months. Then after that we have the Which is the last primary teeth? Last primary teeth. The last primary teeth is what? M2. That is developed at 18 months. That is 18 months. This is the last primary teeth. Which is the first permanent teeth? First permanent teeth. This is the which is the first permanent teeth. What is that? That is the first molar. First molar, and where it will at the 6 to 7 year. Which is the last permanent teeth? Last permanent teeth. Last permanent teeth is which one? Which is the last? M3. The list is M3 and develop at the 18 years. है ना? Okay, this you need to remember. Which is the first primary teeth? The lower central incisor develop at the 6 to 7 month. Last primary teeth M2, that is developed at the 18 month. First permanent teeth, first molar 6 to 7 year. Last permanent teeth M3, that is at the 18 years. I hope this is clear and this is done. Okay, so just revise everything till here and then we will continue. There are some other formula as well that we will continue. You have the 2 minutes break I will give after this thing, and so just keep revise. Just give a quick read to everything. I hope this is clear. Okay, so let's continue with that. So I'm repeating it again. There is a prenatal condition. So when we call it ovum. So there is a prenatal conditions when we call this as ovum, that is 0 to 2 weeks. Embryo we called it when it will become 3 to 8 weeks. When the baby will be when it will be like on the during the gestation period we are talking about, with the before the delivery. So we have the fetus, we call this as 9 week till the birth, and the neonate will call it 0 to 28 days. Early neonate 0 to 7 days. Late neonate we call it 7 to 28 days. Postnatals we have the toddler 1 to 3 years. Preschool 3 to 6 years. School we have the 6 to 12 years. In day 28 to 1 year we call this condition as the infant. The normal weight you need to remember, that is 2.5 to 4 kg. The normal weight you need to remember, that is 2.4 to 2.5 to 4 kg. Average weight of the baby is 3 kg, that is 2.8 kg. Okay, that you need to understand. Low birth weight less than 2.5 kg. Very low birth weight less than 1.5 kg. Extremely low birth weight, that is less than 1 kg. The expected weight of the 1 year 10 kg. Weight double by 5 months and triples by 1 year. And also remember one more thing here. Also remember one more things, like they can give you in between the details also. So if you are getting the expected weight, if you are if wanted to know about the expected weight, so expected weight, remember, it is calculated if you have the less than 1 year old. For the less than 1 year old, what the expected weight formula will be there, that is x plus 9 by 2. What is the expected formula? Expected weight formula, that is x plus 9 by 2, and x is here age in months. What is the x? Age in months. Age in months of baby. The age in the months of baby. Okay, age in months. Then if we talk about the, like we have the 1 to 6 year old. If the baby is 1 to 6 year old, then we have the expected weight is the 2x plus 8. 2x plus 8. But if more than, or like 7 to 12 years old, then that in that cases the expected weight will be equal to the 7x minus 5, 7x minus 5 by 2, and x here, here and here, the age in years. This is the age in years. Here the age, or this is x, so this is the age in years. Okay, that you need to remember. See, x plus 9 by 2, you don't just mug up it 5 times. X plus 9 by 2, x 2x plus 8, 7x minus 5 by 2. X plus 9 by 2, 2x plus 8, 7x minus 5 by 2. 2x plus 9 by 2, 2x plus 8, 7x minus 5 by 2. X plus 9 by 2, 2x plus 8, 7x minus 5 by 2. That you need to remember like that, and you will be able to recall easily. And remember that for less than 1 year old, of course, we have the months baby, like 6-month baby, 4-month baby, 5 months. So that's why we will calculate the age, or we remember the age in the months. Okay, that you need to remember. Then height formula, you need to remember this formula as well. Age into 6 plus 77. The age into 6 plus 77, that is the height formula. For length measurement, you need to remember the infantometer. For height measurement, we have the stadiometer. Dental formula for the adults, 2123, and this is for adults. Dental formula for adults. And for the children's, remember the dental formula. For the children's, remember the dental formula, that is 2102. 2102. Okay, this is the dental formula for the children's. Okay, then also remember, if you are calculating the number of the teeth, if you need to calculate the number of the teeth, so always remember you can calculate with the help of the formula. The number of teeth is calculated is the x minus 4, and x is the age of baby in months. The age of baby in months. For example, we need to calculate the, in the questions that we ask, that according to questions, we have the 1 year baby. If the 1 year baby, so 1 year we have the 12 months. So for that, the number of teeth will be equal to the, this is number of the teeth n. So this will be equal to the 12 minus 4. So the number of teeth will become the 8. That was our questions. I hope this is clear. Now let's see the question. Say mother, so we are getting, he is 1 year old, so what the teeth of baby? So again it will be the 12 minus 4, so it will be the 8. So total teeth will become the 8. I hope this is clear, and this is all the milestone that we discussed. Okay, no questions. Okay, that's good. Then understand the thing. See, this is 12 minus 4, 8. So here is the mother consulted a pediatrician about her son. The son was born with the body mass of the 3 kg, and length is 48 centimeter. He is 1 year old now. What is the required normal mass? What is the required normal mass? So he consulted a pediatrician about her son. Her son was born with the body mass of the 3 kg and length of 48 centimeter. So he is 1 year old now. What is the required normal mass? See, just I told you the formula. Apply the formula and get the answer. What will be the formula? If there is a less than 1 year old, so what we will use? If the less than 1 year old, what the formula? X plus 9 by 2, and x in months. Like if there is a, I will say, if it is 11 months, so 11 plus 9 by 2. So what is the answer? 20 by 2, that is the 10 kg. है ना, for the 11 month. But for 1 year to the 6 year old, I told the what is the formula? The formula for that is 2x plus 8. The 2x plus 8. So we have the 2 multiply age in years. So we need to calculate, that is the 2 plus into 1 plus 8. So again it will become the 10 kg. Okay, but we can assume that you have the 10 kg here. We cannot calculate the, if it will calculate this formula from this formula, it will become 12 plus 9, so it will become the 10.5 kg. Okay, so you need to remember that if it is like, if they ask you about the more than 1, you can remember it like this. If it is more than 1, then you need to calculate with this formula. If it is less than 1 or equal to 1, then you need to calculate with this formula. Okay, so I hope this is clear. If it is less than 1 or more equal to 1, then you need to calculate there also. Less than or equal to 1, equal to 1 year old, and here is more than 1 year old to 1 to 1 6 year old, that is 2x plus 8. We is in years, that you need to calculate. Okay, so the answer is the 10.5 kg. A 6-month-old infant was born with a body mass 3 kg and length. He is given natural. How many times per day the infant should be fed? That you need to remember. These questions ki how many times per day. So normally, usually the per day, it should be like 6 or the 7 or whatever. Like, but minimum dose according to the Croc 2 point of view, the minimum dose that we should give or which infant should be fed, that is the 5. That you remember or mug up it. Remember it, like how many times per day, minimum time per day the infant should be fed. So that is what, that is the 5 times minimum should be feeding. Okay, so just revise this thing till now, and when we start 10:30. Okay, I think 10 minutes break will be enough. So take the 10 minutes break, and after the 10-minute breaks we will continue. Okay, please show the last part of the notes. Okay, Madam Ji, ye lijiye. Number of teeth x minus 4, age of baby in months, 1 year, 12 months, and age goes to, and I will make it little slow so you can see this as well. Okay, so see you after 10 minutes. Take a break, drink water, and come back after 10 minutes. Okay. मैं तो नहीं हूँ इंसानों में, बिकता हूँ मैं तो इन दुकानों में। मैं तो नहीं हूँ इंसानों में, बिकता हूँ मैं तो इन दुकानों में। फिर रहा हूँ ढूंढता मेरे निशान, है कहाँ मेरे निशान। Okay, so Bajo. Come back. Come back. Good morning. Good morning. Wake up, guys. Wake up. I hope everyone came. So let's start. Should we start? 19. Yeah, everyone's came, I think. Okay, so the questions that we just did, and so here we have the 6 month. I think this one we already did. 6-month-old infant was born with the body mass 3 kg and length is 50 centimeters. He is given natural feeding. How many times per day the infant should be fed? Okay, so this one is done. This one is done. So they could see we have the 6-month-old infant. So normally what we do. Is my voice clear? Hello. I think I put somewhere. Hello. 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 Okay, so it's 6 months. So see, at the 6 month, what we do? We do the. So you need to remember how many times infant should be fed after 6 month old. So that is the 5 days. But remember for that, if you have the 6 month old infant is there. So at the 6 month old infant, like less than 6 month, the less than 6 month, what we need to do? We need to take the breastfeedings, that is compulsory breastfeeding or exclusively breastfeeding exclusively. The only and only breastfeedings is mandatory for the less than 6 months. But after more than 6 months or with like at the 6 months, what we can do? We can do the like the patients will can give the artificials or the baby we can give the artificial feedings. We can give the artificial feedings. So exclusively breastfeeding, remember it will be done till the 6 months. But artificial feedings when we given after the 6 months. Now remember that if we will be having the artificial bleedings, so the number of feeding is required. The first month what we will give the 7 feed. You need to remember all these things. First month you need to give the 7 feed. The 3.5 months baby, you need to give the 6 feed. 3.5 months baby, you need to give the 6 months, and at the more than 6 months, you need to give the baby, that is the 5 feed. But the 5 feed, this is the 7 feed, that is exclusively breastfeeding. Here the 6 feed, that is again the exclusively breastfeeding, and here is the 5 feed. Out of them 3 is the breastfeed, 3 should be the breastfeeding, and out of them 2 will be the artificials. Okay, so at that more than 6 months or equal to 6 months, equal to the 6 months, how many feed we should given? 5 feed, and out of them 3 should be the breastfeedings and 2 should be the artificial feedings. So that's why it becomes a 5. Okay, I hope this is clear. Then remember the next. Let's discuss the next questions. Infant is 6.5 month old month now and is given the natural feeding since birth. So he is getting the natural feeding since birth. Okay. Body mass was 3.5 kg with length. How many times per day the supplement should be given? See, up feeding means supplement means artificial feeding. That is artificial. So what is the artificial feedings at the 6.5 months? That is 2. That is 2. Okay, I hope this is clear. Now the next questions. And 2-month-old healthy infant with the good appetite is given artificial feeding since he turned 1 month old. He turned 1 month old. When you will recommend to start the corrective feeding or the fruit juice? When you will start? I just told you that till the 6 month exclusive breastfeeding is necessary for the baby, and after 6 months we can add, or at the 6 month we can add the some supplement or the artificial feeding. So might be there will be some correction here, that is it should be how many months? It should be the 6 month. It should be 6 months. So correction, do correction here, it will be 6 months. 6 months we will recommend 6 months we will recommend. Okay, so mark the do the correction here, that is the 6 month. See this questions, an infant was born with a body mass 3 kg, body length 50 centimeter. Now he is 3 years old. His brother is 7 and suffer from the rheumatic fever. Mother asked the doctor for a cardiac checkup for 3-year-old. Sir, what is the left relative heart border located? The 1 centimeter left from the left midclavicular lines. This I am sending you one image. So study from there only. Because at my times it is not like so much good explanation for these questions, because this is not a like completely medicines thing. So there is heart related dullness, you can remember with this table. See if they have the I'm repeating this table. See, okay, sorry, I sent in the wrong group. Share in the wrong group. Okay, now you got the table. See if you have the borders, so border until the 2 years, you can remember that there is a right or parasternal right upper. On the right side we have the right parasternal light shift and the second ribs and 2 centimeter outward from the left. If the borders, you can remember the borders, all the borders, and you can remember just this question only, 1 centimeter left from mid clavicular lines. I hope you all knows the when we hear the sounds. So we all know all people eat Turkish meal. All people eat Turkish meal. Okay, so aorta, we know aorta, we know the pulmonary. Then we have the Avs point. What is the Avs points? We studied in the brachial plexus when most of the arteries they meet to each other. That is the point where these arteries meets. Okay, so the Avs point, remember that we have the tricuspid and we have the mitral. Tricuspid and we have the mitrals. So remember this aorta, we have the, for the aorta and the pulmonary walls, we have the second intercostal space. We have the second intercostal space where we will hear the sound. At those point we will hear at the third intercostal space. Tricuspid we will hear at the fourth intercostal space, and the mitral walls they present at the fifth intercostal space, and there we will hear the sounds. Okay, these are the presenting of the all the aorta, pulmonary trunks, and the Avs point, tricuspid, and the mitral. So remember these things. And remember, if you have the where the left relative heart borders will located, so it is 1 centimeter left from the left midclavicular lines, and you need to understand this table as well. Okay, now not important questions that I am not giving the focus here. A boy of 7-year-old had attack of asthma. See if there is attack of asthma, I told there is a whistling rails can be there after playing with a dog. In the medical history, there is atopic dermatitis that is caused by eating eggs, chicken, beef. What group of allergen is the region of the development of the bronchial asthma type? See, when we are talking about we already know about the type 1 hypersensitivity. Type 1 hypersensitivity, what we call this condition? It becomes so much. So the type 1 hypersensitivity, what we call this condition as the hypersensitivity. The type 1 hypersensitivity, always remember there is the immediate type of hypersensitivity, and it is what? It is the like due to any allergens. Like it can be the urticaria, or the examples we study like beehive, urticaria, or any allergens, and what are the examples we studied for that condition? That is the bronchial asthma. So this one we already studied. Bronchial asthma. So what is the what is the group of allergens? So remember the epidermis, the bronchial asthma is here, that is due to contact. So when the person will be in the contact, the contact of the eggs, the chicken or the beef, so in that patient, the patient will having the symptoms of the bronchial asthma. So always remember the bronchial asthma, and when it will be there, when it will come in the contact with the person, so which group of allergens will be there, that is involve the epidermis, that is the epidermis, or you can make it biological. See, they not chemicals, not pollen if it will pollen will be there, it will be related to the any any flower or anything. It will not including any dust, because there is some edible parts will be there, that is for eating parts, and the itch mite, that is not given any history of the itch mite is there. They're giving some food is there, so the food is there means that is the involved with the epidermal group of allergens, that is comes in contact with the persons, and that will lead to the symptoms of the bronchial asthma. Okay, I hope this is clear. Can you quickly show question number 20? Please for a quick second. Question number 28. Yes. To all people eat Turkish meal. So aorta, pulmonary trunks, Orb's point, tricuspid mitral, second intercostal space, third intercostal space, fourth intercostal space, fifth intercostal space. Okay. See, a 14-year-old boy has a rheumatism or the rheumatic fever is there. Over the last 2 years, he has had three rheumatic attacks. So, what course of rheumatism does the patient have? See, the questions that will come here, that is the little bit confusing questions, but you know, no need to worry. See, if you have the rheumatisms in the question already they give, if they have the rheumatisms or any rheumatic fever is there. So, over the last 2 years, he has the 3 rheumatic fever. So what course of rheumatism does the patient have? So patient have one, then second, then third attack. So it is what we condition, what course we called it is. It is known as the prolonged course. That or we can say the chronic conditions. It going to the chronic conditions. It's occurring very rapidly. Within the 2 years, we got the 3 attacks. So that's why we call this condition as the prolongs. When it will be the recurrent, if it is completely subsides, but after that again it become the again the it comes, that we call the condition as the recurrent. Acute conditions, acute or subacute will not be there, because it's not within the few within the few days, but it's occurring after the years. That's why it will not be acute or subacute. Okay, and also remember what course it should be, what course also there is some I think we can consider this question as like this also. What course of rheumatism does this patient want, or what we can give this to the patient? So we need to give the prolonged treatments. So that's why I'm saying that what the course of rheum they already have, so they can having the prolonged treatment as well. So that you need to understand, because we studied in the rheumatic heart disease, where we studied that if there is a carditis and everything is possible, so in that conditions, if the patient having the complications of the rheumatic heart disease, in that conditions we will give the lifelong treatment, or at least till the 24 till 41 years. So that's why we will give the prolonged course for these patients of the rheumatisms. Subacute or acute conditions, like the similar things. Acute, subacute, those are both are the similar things. Like note a little bit difference, like acute, subacute, and then chronic, so that you can understand. Subacute, sub means below the acute regions, or so you can remember subacute, then acute conditions, latent phase, and then chronic phase will be there. यहाँ पे तो सिंपल है. दिस इज वन ऑलरेडी हमने डिस्कस कर चुके हैं इन द केस ऑफ द रूमेटिज्म्स कि इन द रूमेटिक अटैक्स व्हाट क्या हम देंगे. ठीक है. इफ acute rheumatic fever patients having the complication of the rheumatic heart disease, in that conditions we will give the lifelong treatment. That's it. The patient has acquired heart failure, diastolic pressure of the 0 mm. What the heart failure does the patient have? See, the patient has acquired heart failure. This is again the question that we will discuss in the cardiology part. So just for this question, remember, if have any heart failure is there, see, if there is acquired heart failure and the diastolic pressures you are getting the 0 mm Hg. So we having the phase like if I'm talking about the heart phase, so we will having the left atrium, so we will having the left ventricles. So the left ventricles are everything you will understand when we will discuss about the JVP and everything. You know, JVP is the most very important topics, and there we will discuss. So this left ventricular will having the diastolic pressures when there will nothing will be in the bloods and it will be the empty. So at that time the diastolic pressure is there, so it means there is the aortal insufficiency, that we are not getting any pressure in the diastole. So the heart is not able to relax properly. That's why the problem in the aorta. I hope everyone knows that from the left ventricles we have the artery, that is the aorta. We already discussed these things in our topic where we discuss about the Steele syndromes. I make one diagram there as well. So where we discuss the Steele syndromes, and there we also tell you that from the left ventricles we will be having the arc of aorta or the ascending aorta. Then from the right ventricles we have the pulmonary aorta. So if you have the diastolic pressures, because of heart failure the most common jo ventricles hai, that is we have the left ventricle, and the major ventricles is also the major chamber is also the left ventricles. So if any problem in the aortic insufficiency, the diastolic pressures will be the 0. So for now you just need to remember these things, that if the left ventricle is the major chamber, and in the left ventricles if we having the pressures level will be 0, so diastolic pressures will be 0, so that will be having the problem in the aorta insufficiency. Everything we will cover, and I will repeat that questions there. Okay, so when we will discuss about the JVP and OLS, so everything will be covered there. Okay. That 12-year-old child has an ulcer disease of the stomach. What is the etiology of the disease? Again, a one controversial question. See, if there is ulcer disease of the stomach, what is the etiology of the disease? Tell me. You will tell me if there is ulcer disease of the stomach. What is the intestinal bacillus and what is the Helicobacter pylori? Right? Okay. Okay, this will not be the answer. This one you can mirror. But see here, there is an intestinal bacillus, and one option we have the Helicobacter pylori. है ना? So if there is ulcer disease of the stomach, so of course I told you that there is Helicobacter pylori is there. है ना? So here is what intestinal bacillus. So I think so. The answer should be here the Helicobacter pylori, but it's given the intestinal bacillus, so I can't do anything. Maybe it's the previous base or so whatever the examples. I think in the test center website the answer is the Helicobacter pylori. So better you go with the Helicobacter pylori. Forget these things. Or if you get any questions in the test center website, mark that answer only in exam also. Whatever in the test center website, mark that answer only. Whether you are correct, whether you are not correct, it doesn't depend. Whatever the answer is, the test center website, you need to choose that answer only. Okay. If they're saying the salmonella is answer in the C, if the salmonella one time or two time, there can be the like in the one question you can get the salmonella, and other questions you are getting the answer Helicobacter pylori, and you are seeing that the Helicobacter pylori is the correct answer. Yes, then choose the Helicobacter pylori only. But if you are seeing lot of questions in which you are seeing like something the salmonella every time, everywhere the salmonella is given, then mark the salmonella. This is just an example of what I'm saying, that whatever the questions like the controversial questions, whatever the questions answer mark in the test center website, choose that answer only. Okay, here there is no doubt intestinal bacillus, this can also be correct, because of course this is the bacteria, so that's why it also involved in the intestine, that can also be the correct answer, but the most preferred answer here is the Helicobacter pylori, because they're talking about the stomach, they're not talking about the intestinal. That's why. Okay, I think we need to finish this today, and rest we will discuss tomorrow. A little bit, and we will discuss. Tomorrow we have the big topic of the one. Tomorrow the big topic we will discuss. Okay, Bahira, I will discuss. There is a chest X-ray. So all these things, this one we will study about the celiac disease and these things. Then we will study about the yesterday about the esophageal atresia. We will discuss about the Apgar score, that is important. Then we will discuss about the RH incompatibility. This one we already done. So there is exchange of the blood transfusion. Then we will discuss something about the atelectasis, and every lung pathology we will discuss. All the lungs pathology we will discuss tomorrow. So this is the big topic for tomorrow. Bronchitis, pneumonia, pneumothorax, emphysema, hydrothorax, hydropneumothorax, everything we will discuss. This one we will also discuss. After that we will having, I think they put the about eosinophils. Okay, the big topic for tomorrow is what we have we will discuss everything about the lungs pathology. Okay, so see and Dana 6 feet 5 feet. See 6 feet 5 feet 6 feet 5 feet. See in the when we are doing the first months, so in the first month we will give the 7 feet to the baby. 7 feet to the baby means we will give the 7 times breastfeeding. 7 times breastfeeding. 7 times breastfeedings will do in case of the first month. In 3.5 months we will give the 6 times breastfeeding. 6 times breastfeedings. Okay, thank you so much. And more than 6 months we will give the 5 feeds. So 5 means we will give the first 3 breastfeedings and the 2 artificial feedings we will give. I hope this is clear, and please revise everything, and I want you to revise everything again and again so that you will able to recall, and that will help you not for the croak exams but will help you for the further exams as well. And please be prepared for the Wednesday exams as well.